Well, good morning, everybody. I wanted to thank Brian for putting together this conference. And all my colleagues at the Long Island Plastic Surgical Group. I'm going to talk to you today about trigger finger, pediatric trigger thumb, and Dequervain's tenosynovitis. All of them are fairly similar. There are some nuances between each one, but all of these come under the umbrella term of a stenosing tenosynovitis. And the words to describe this problem have changed over the years, and so there's a lot of synonyms for the same thing. And I'll go over some of that. But these are very common problems that we see in hand surgery, and I'm sure all of my colleagues can agree. We see these almost every time we have a case. So as far as an overview, I'm going to go through the incidence, pathophysiology, treatment options, complications, and outcomes. So what is the best available evidence for this? In the past 5 or 10 years, there have been all of these studies that have been done, kind of trying to group together all the studies that were done for many years to come to some sort of consensus opinion as to how to treat these. And it's interesting, when I look through all the new data regarding this, it's pretty much what we thought was the case, except for some small things. So even just on anecdotal evidence and experience, without these huge studies that were done, we knew how to treat these the same way. So it brought me to the question that we ask every hand surgery patient, and what is your occupation? And it's because these are all repetitive use type injuries and problems. And this is credited with Bernardino Ramazzini. And around 300 years ago, he wrote a book about this, and he's all over the internet, basically. And he's been credited with this because in those, back in the day, everyone was using their hands and having problems, and so this was one of the first descriptions of this. 300 years go by, and we're still using our hands in many different ways that are causing these repetitive use injuries. And you can see, and Dr. Davenport touched upon this with the ergonomics, everything we do is probably not the best thing for our flexor tendons or our extensor tendons. And that includes using mice and using the computer, and we're probably, and plus with everything else, you're going to get these problems. And this leads us to the future of the interface between computers and our hands. And these are the so-called air mice that are out there, and people are trying to invent a new way of interacting with computers. And so this may bring its own problems as the years go on, or it may bring the same problems. I don't know if it will solve the problems that we have with repetitive use, but these things are not going to go away, and so this will continue to be a problem. So what is trigger finger? It's a stenosing tenosynovitis. It's characterized by pain, catching, or clicking, locking of the fingers. Sometimes it presents as a fixed flexion deformity. And it's a pretty high lifetime risk, 2.6% lifetime risk of getting this. And there's an increased incidence of diabetes and inflammatory arthritides, and a higher prevalence, and so the prevalence increases from 5% to 5% or 36%. And these are some of the associated conditions. So the other conditions we're talking about today, carpal tunnel, Dequervain's, they're associated with trigger finger. The other systemic diseases you can see here, hypothyroidism, rheumatoid arthritis, renal disease, and amyloidosis. All of these have a sort of higher prevalence for this. So pathologically, what's going on, and why are we getting this problem? And you look through the literature, there was some confusion initially whether it was the A1 pulley or whether it was the tendon that was getting swollen. And it seems like now everybody thinks it's the tendon that's getting swollen, sort of in a spindle shape that you can see here. And that sort of gets caught generally at the A1 pulley. And the reason for that has been, why just the A1 pulley? When you look at the side view of this schematic of the A1 pulleys and the cruciate pulleys, you have to slide the flexor digitorum superficialis and profundus through these small tunnels. And so it's not a surprise that if you use it over and over again, that it will get swollen. And the A1 pulley seems to be the one where the most problems occur. The A3 pulley has been a flexor tenosynovitis at the A3 pulley described in bowlers, but that's very uncommon. So why the A1 pulley? So looking through a lot of the information, it's basically because there's just a higher angular load in that area at the metacarpal phalangeal joint, and that's causing the inflammation at the A1 pulley. So the Quinnell classification is something you don't see much clinically day to day. There's been about 5 or 6 different classifications of this disorder over the past 20 years. The other classification was the Eastwood classification of trigger finger, which I wish was more popular because that would be much easier to remember. And you have, with the Quinnell classification, you have grades 1 through 5. And 5, basically, they present as a fixed flexion deformity. And grades 1, 2, and 3 are much more mild. And as I go through the next several slides, the grades 1 through 3 are very much more responsive to conservative therapy, and 4 and 5, as it gets worse, surgical therapy is probably a better option. So with all of these, including Dequervains and including trigger finger, you have non-surgical treatments and surgical treatments. And the